Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's February 2025 issue. There are 3 articles that have been selected as our Editor's Choice or Highlights articles this month. Our Editor's Choice this month is an original article entitled Effects of Tirzepatide on Body Weight and Diabetes Control in Adults with Type 1 Diabetes and Overweight or Obesity. It is authored by Dr. Rene D.J. Rivera Gutierrez from the Division of Endocrinology, Diabetes and Metabolism at Mayo Clinic in Jacksonville, Florida, and colleagues from Mayo Clinic in Rochester, Minnesota. Anti-obesity medications such as tirzepatide, a glucose-dependent insulinotropic polypeptide, and a glucagon-like peptide-1 dual agonist represent a major therapeutic advancement. Rivera Gutierrez et al. Examined the efficacy of tirzepatide in achieving weight loss in patients with type 1 diabetes who were also overweight or obese. This study addresses an important issue for several reasons. First, patients with type 1 diabetes are just as likely as the general population to be overweight or obese. Second, the prevalence and incidence of type 1 diabetes are increasing worldwide, as are the prevalence and incidence of obesity. Third, the concomitant presence of obesity exaggerates the risk of cardiovascular and other diseases incurred by type 1 diabetes. Fourth, attempts to reduce body weight in type 1 diabetes may incur the risk of hypoglycemia as physical activity is increased, caloric intake reduced, and insulin regimens modified. Rivera Gutierrez et al. Undertook a retrospective study of adults with type 1 diabetes at Mayo Clinic with a BMI greater than or equal to 27, in whom tirzepatide was used for weight reduction during the period June 1, 2022 to October 31, 2023. 51 patients with type 1 diabetes fulfilled the requisite criteria, with the majority of patients being female, white, and exhibiting class 3 obesity. Tirzepatide led to significant weight reduction, with 10% weight loss at 8 months and 14% weight loss at 12 months. Treatment with tirzepatide was associated with reductions in hemoglobin A1C and in total daily insulin dose and meal total insulin dose. The decrease in insulin dose was most marked within the first 6 months of therapy with tirzepatide and plateaued thereafter, notwithstanding continued weight loss. The use of tirzepatide was also attended by significant decrements in diastolic blood pressure, total cholesterol, low-density lipoprotein cholesterol, and triglycerides. Finally, there were no significant side effects. In particular, the incidence of hypoglycemia did not increase in patients treated with tirzepatide, nor did diabetic ketoacidosis occur in patients so treated. To date, this is one of the largest studies that has examined the efficacy and safety of tirzepatide in weight reduction in overweight or obese patients with type 1 diabetes, and the only one available that also examined whether cardiovascular risk factors are concomitantly altered. Our first highlight article this month is a commentary entitled When Patients Present with Direct-to-Consumer Pharmacogenomic Test Results. It is authored by Dr. Roseanne Donnelly from the Department of Pharmacy Practice at the Massachusetts College of Pharmacy and Health Science in Boston, Massachusetts, and colleagues from several national universities and centers. This commentary by Donnelly et al. Is on behalf of the Direct-to-Consumer Genetic Testing Project Group of the National Human Genome Research Institute Inter-Society Coordinating Committee for Practitioner Education in Genomics. Direct-to-consumer genetic testing is attracting an increasing clientele, as such testing may provide insights regarding ancestry, personal characteristics, and the propensity for disease. Pharmacogenomic testing analyzes genetic variants which can influence the efficacy of and/or the adverse effects of drugs. The results of such testing are often communicated by patients to their providers, who are then asked to comment on and/or discuss the medical relevance of such testing. Donnelly et al. Define and discuss, among other issues, such salient considerations as direct-to-consumer genetic testing, pharmacogenomic testing and how it can be accessed, the significance of clinically actionable pharmacogenomic testing variants, laboratories that are Clinical Laboratory Improvements Amendments, CLIA certified, and thus ones that attain requisite analytic rigor and regulatory standards. The assessment of the quality of a pharmacogenomic test, as for example as recommended by the Association of Molecular Pathology. And finally, resources that aid the interpretation and the application of clinical pharmacogenomic test results in patient care, including, among others, FDA-approved drug labeling, Clinical Pharmacogenomics Implementation Consortium Guidelines, and the Pharmacogenomics Knowledge Base. To guide the clinician when a patient presents with direct-to-consumer test results, Donnelly et al. Provide a helpful algorithm that begins with determining the reason for the patient undertaking such testing and reviewing the patient's medications, determining whether the results are FDA authorized for clinical use, and if not, the need for confirmatory clinical testing from a CLIA certified laboratory as clinically indicated or because of the patient's interests. The use of evidence-based resources to determine the presence of clinically relevant variants, determining the significance of the pharmacogenomic testing results with regard to the patient's medications, the application of test results to clinical decision-making and documentation in the electronic health record, and finally, education of the patient about the test results. Donnelly et al. Complement their overview of this topic with an instructive clinical vignette wherein a patient presents to her provider pharmacogenomic test results from a direct-to-consumer genetic testing kit, the latter a gift from her daughter. Indeed, certain genetic variants were found to be relevant to the patient's current medications. As understanding of the genetic determinants of disease increases, as medical therapeutics continue to expand, and along with it an understanding of how genetic variants influence therapeutic outcomes, this field will be of ever-increasing importance and influence. Donnelly et al. Are to be commended for distilling the essential and timely issues in this dynamic field. Our second highlight this month is a concise review entitled Esophageal Motility Disorders, a concise review on classification, diagnosis, and management. It is authored by Dr. Anila Vasareddy from the Division of Internal Medicine at the University of Pennsylvania Health System in Philadelphia, Pennsylvania, and colleagues from Mayo Clinic in Rochester, Minnesota, and Cedars-Sinai Medical Center in Los Angeles, California. Dysphagia is a relatively common symptom, especially so in older individuals. As pointed out by Vasareddy et al., esophageal motility disorders are insufficiently recognized in underlying such symptoms. Some 25 years ago, Mayo Clinic Proceedings highlighted this topic by providing a concise review authored by Adler and Romero. Vassaretti et al. Update this topic by reviewing the differential diagnosis of esophageal motility disorders, how the diagnosis may be reached, and the management of esophageal motility disorders. Initially, it should be determined whether oropharyngeal or esophageal causes account for dysphagia. Evaluation of esophageal dysphagia then proceeds with an EGD so as to disclose any structural causes, as well as providing therapeutic procedures such as dilatation. After the exclusion of structural causes, esophageal motility disorders should be differentiated into a primary process originating from the esophagus or as a secondary one due to systemic disease. Primary esophageal motility disorders may reflect either disorders of the esophago-gastric junction or disorders of peristalsis. Disorders of the esophago-gastric junction may reflect either achalasia, of which there are 3 subtypes, or esophago-gastric junction outflow obstruction. Disorders of peristalsis are divided into either hypomotile or spastic disorders. Hypomotile disorders may be due to either absent contractility or ineffective esophageal motility, while spastic disorders may reflect either distal esophageal spasm or hypercontractile esophagus. The authors underscored the importance of the Chicago classification version 4.0 for the differential diagnosis of esophageal motility disorders and the fundamental contribution of the high-resolution esophageal manometry in establishing the diagnosis. This test provides, among other metrics, the integrated relaxation pressure, distal contractile integral, and distal latency. Based on high-resolution esophageal manometry and, if needed, adjunctive tests such as the time-barian esophagram and the endoluminal functional imaging lumen probe, the specific cause of esophageal motility disorders can be determined. Securing the diagnosis then informs the selection of the appropriate and specific therapy, which encompasses, among others, the following: dietary modifications, lifestyle changes, pharmacologic therapy, pneumatic dilation, laparoscopic myotomy with partial fundoplication, per-oral endoscopic myotomy, and endoscopic botulinum toxin injection. The availability of a discerning, expert-formulated disease classification that is primarily based on a valid and reliable test so often significantly advances fields in medicine, and as underscored by Vassaretti et al., such is entirely the case with the Chicago Classification 4.0 and high-resolution esophageal manometry. You can access these highlights and editor's choice articles free of charge during the entire month of February. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage based on articles published in Mayo Clinic Proceedings. You will see other free content as well as articles published online in press. You will also find links to our social media by clicking the links in the gray bar at the top of the homepage from the Connect menu to follow us on Facebook, X, formerly known as Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights and our MCP 60 seconds video article synopses. We invite you to check out our newest addition to our Pioneers and Legends in Medicine video, featuring Associate Editor Dr. R. Scott Wright interviewing Dr. Leonard Berry. In addition, our website also includes our Mayo Clinic Proceedings issue summary and Author Insight podcast recordings, which are available from our website at the homepage as well as through iTunes. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.